Okay, so after great discussion in Urdu language, now we are going to discuss about uh, cardiac output variables as a reading from the book first aid page number 293 and 294. So about cardiac output variables, first of all, stroke volume. Stroke volume is affected. Stroke volume is affected by contractility, uh, afterload and preload. Stroke volume increase. We should know stroke volume increase with increased contractility, increase preload, and decrease afterload. What is meant by contractility, increase preload and afterload? Next we discuss. Increase contractility examples anxiety, exercise. Increase preload example early pregnancy. Next, contractility. Contractility increase with catecholamine stimulation by beta 1 receptor specially present on the heart, activated protein kinase A, phospholamine phosphorylation, activate calcium ATPase, increase calcium storage in the sarcoplasmic reticulum. This concept is like that. For calcium storage in sarcoplasmic reticulum in the heart, we must first of all phospholamine. The process is occur phospholamine phosphorylations, and this process lead to the activation of protein kinase A, which lead to increase the calcium storage in the sarcoplasmic reticulum. Activated protein kinase A calcium channels lead to calcium channel phosphorylations, increase the calcium entry into calcium, and when the calciums enter from the extracellular into intracellular, then increase calcium in the inside the cells lead to a process known as calcium induced calcium release. Okay, by this increase calcium concentration in the cell. Intracellular calcium increase lead to the contractility, increase the contractility, decrease extracellular sodium, and next MCQ's point of view, this one is important. Digoxin is a blocker sodium potassium, it is the pump, increase the intracellular sodium, decrease the sodium and calcium exchange activity, increase the intracellular calcium, and this is one of the important point. For digoxin uh, use a block to the sodium and potassium pump, increase the intracellular sodium and decrease the sodium calcium exchange activity, increase the intracellular calcium. And we know when the intracellular calcium will increase, then lead to the increased contractility. This is important also. Important one, contractility it decrease with beta 1 blocker, decrease cyclic AMP, heart failure with systolic dysfunction, acidosis, hypoxia, hypercapnia, and non-dihydropyridine calcium channel blockers. Okay, this is for decreased contractility of the heart. Next, preload. Preload approximated by ventricle and diastolic volume when on venous tone and circulating blood volume. And this is MCQ's vasodilator. We know when we give a vasodilator, then decrease the preload, and decrease preload lead to the decrease. When we give the vasodilator, decrease the venous lead to the decrease the preload. Afterload is approximated by mean arterial pressure, increase wall tension per laps, increase pressure, increase afterload. Okay, next up, arterial vasodilator and also MCQs. This is MCQs hydrolazine. Hydrolazine is a arterial vasodilator and decrease the afterload. AC inhibitor. AC inhibitors are angiotensin receptor blockers. Receptors decrease both preload and afterload. Okay. Next, chronic hypertension increase the mean arterial pressure. Left ventricle hypertrophy can lead. Left ventricle compensate for afterload by thickening in order to decrease wall stress. I think clear. Next, uh, Myocardial oxygen demand. Myocardial oxygen demand is increased by contractility, increase after load, increase heart rate, increase diameter of ventricle. And this is also important. Wall tension follows relapse law. Wall tension is equal to pressure multiply radius. Wall stress inversely pressure multiply radius and 2 multiply wall. This is a formula we already discussed. Okay, so नेक्स्ट पेज नंबर आपके पास है पेज नंबर 9294 stroke volume formula for stroke volume is equal to n diastolic volume and end systolic volume minus end systolic volume. End systolic volume ejection fraction is equal to stroke volume divided by end diastolic volume is equal to end diastolic volume minus end systolic volume divided by end diastolic volume. So, ejection fraction is an index of ventricular contractility, decrease in systolic heart failure, usually normal in the diastolic heart failure. Cardiac output is equal to stroke volume multiply heart rate, already discussed. Okay. Next, pulse pressure. Pulse pressure, PP, systolic blood pressure minus diastolic blood pressure is equal to pulse PP. PP directly proportional to stroke volume and inversely proportional to arterial compliance. Increase PP in hyperthyroidism important. Pulse pressure increase in hyperthyroidism, aortic regurgitation. MCQs important regarding MCQs. Increase PP in hyperthyroidism, aortic regurgitation, aortic stiffening. Isolated systolic hypertension in elderly, obstructive sleep apnea, increased sympathetic tone, anemia, exercise transitive, decreased PP in aortic stenosis, cardiogenic shock, cardiac tamponade, advanced heart failure. Mean arterial pressure is equal to cardiac output multiplied total peripheral resistance, already discussed. So this is about basic terminologies regarding cardiac output variables, cardiac output equations. Thanks for your attention.